So next will be Sushmita, who will be speaking to us why accurate phenotyping is so important. So those of you who have questions, maybe we will take the questions at the end of this session, or you can either ask us or maybe write it on a slip and then pass it on. So we'll give time for Sushmita.
Good morning. We see a couple of more people, so that's nice. I think this will be another perspective on Dr. Mandal's talk as to why we nowadays understand that phenotyping actually has implications for not just the diagnosis, but also the management that we do. So the problem is that the childhood glaucoma can be very similar on the surface, right? They all come with babies with white eyes, and yet there are myriad hues underneath. So you have no idea what lies beneath these still waters. We've taken informed consent because we've shown pictures of these babies, but then the context is much better when we see them. So the outline would be what we've learned along the way and what we do every year. I think all of us say something different the year after and the year after, and it's been very humbling that what we thought we knew actually turns out to be what we actually didn't. And I'll show some snapshots of phenotypes and one or two pearls on the importance of why I think accurate phenotyping is important. So Dr. Mandal has shown us acute eye drops. The take home is they all do very well if treated in time. So if you have acute eye drops, there's no point saying that my OR next date is 4 months away, because then you would lose the battle. So if you have a person saying, or a mother distraught that this child was perfectly fine 2 days ago and has now become white, so it's important to really intervene fast. And if you can see the picture up there, that's how the Harb's striae actually stretches for all that fluid to get in. But another interesting point was that we noticed when we thought we were dealing with a unilateral glaucoma and we treated the acute eye drops and we weren't doing bilateral simultaneous surgeries, the baby sometimes came back with an acute eye drops of the other eye. So obviously there is something wrong with the desme or the endothelium of these children which predisposes them to acute eye drops of the other eye as well. So we started doing bilateral surgery. This was the only indication of bilateral surgery that we started doing after understanding or observing that. But now with COVID coming in, we do bilateral simultaneous surgery of most children anyway. And after that, we haven't seen acute eye drops in the other eye, because more often than not, you will have some sort of PCG going on in the other eye. It's just that the acute eye drops hasn't manifested as yet. Recently, GAT has been our go-to procedure because it's nice to be able to treat 360 degrees of the angle at the same time. Now, this was a child who, again, classical acute eye drops, and this is, but when we took the kid on the table after a little bit of, by the time the anesthesia and the clearances are done, we always put them on some drops. And then we actually noticed that the cornea seemed to have cleared a bit, even though the look of the angle was very hazy. So this is just a short demonstration of the fact that sometimes you can be foolhardy enough and manage that. So you can see it's very hazy in the center, but we saw that there was one part in the superior nasal portion where we could see the trabecular, the angle. And we said, okay, there's no harm in trying. We can always go in and do a CTT as planned. But then you can see the sutures going in so easily into the Schlemm's canal because it's an acute thing. The Schlemm's is open, and it actually came out from the other side, and we managed the GAT, and this child actually cleared as well as a CTT. So if I can go in and not cut up the conjunctiva and sclera and do a combined trab with trab and get away with a GAT, it's possible. So I thought it's important to say that. So we've been talking about this phenotype. This is classically how the baby presents. Afterwards, of course, they come with completely white corneas, ectropion UVA, severe iris hypoplasia, and they are easily one of the worst glaucomas that I've had to deal with. They all come in the neonatal period. It is not primary congenital glaucoma. We've termed it a neonatal onset congenital ectropion UVA. Dr. Arif Khan used to call it partial aniridia, but he agrees that this is a better term because aniridia sort of connotates PAX6, whereas this isn't. This is a biallelic CYP1B1 cytopathy with very, very intractable glaucoma. In our population, it is R390H. In the Gulf, it is G61E, but whichever is the dominant population in that particular ethnicity, that's how they come with. This baby actually started our rubella journey, and the lessons learned are if you see a white cornea and a small eye and optic disc cupping, think rubella. And the connotation of that is if you think rubella and you test them, you will then think of cardiac anomalies, you will think of hearing defects, and you will think of things that you didn't think of earlier. And we used to miss them, but now neonatal onset, if we have a smaller eye rather than ophthalmos, that is an important pointer towards looking for rubella, at least when we look for it, when we know. CPA has been a heartbreaking journey for just baby. I've shown this many times, but we recognize it very well. The take-home point is a silvery blue hue on the cornea, prompt and ultrasound biomicroscopy. If you don't see the lens, please don't enter this eye because they're usually hypoplastic ciliary processes and they immediately result in an atrophic or a thusical eye. But the also important thing is give them high plus glasses. So this baby is not to be written off. So he has a high plus glass, sometimes not just plus 12. You have to keep on doing a subjective. He's around with a plus 14. I've given them up to plus 17 as well until they can see. And he sees his cartoons and is mobile with his glasses. So the important thing is high plus bifocal lenses. Let's not forget that. Aniridia is a conundrum. Aniridia, it's one of the most intractable glaucomas, especially when they present in childhood. And when you have a family of aniridias, you have a whole family to take care of. This is classical. The corneas are not very large. You usually don't have ophthalmos, and you have very thick corneas. So the IOP recording is something to be thought of. And of course, if they have nystagmus, they have a foveal aplasia like this. But having said that, is aniridia a phenotype or is aniridia a disease? So this preterm baby comes, this is in the OR, you can see there's absence of iris, you can see the edge of the lens, and we just said, oh, aniridia, and that's what the UBM was like, stumps of iris, and fine. When we did the genetics, it was actually FOXC1. And this is a FOXC1 deletion. And when you have a FOXC1 deletion, the iris doesn't form. And we kicked ourselves because when we looked harder, we could then see the telecanthus, we could see the periumbilical skin, and we didn't ask the mother the history, but he also had a ventral hernia which was operated on. So sometimes you miss these things in a busy clinic, but that's no excuse for not phenotyping them better. We should have thought of all that. So if you have absence of iris and there is no nystagmus, and the child seems to be seeing well, think again, because it's a very rare aniridia where aniridia as a diagnosis where you would not have foveal hypoplasia and a nystagmus. So this is again absence of iris, spot diagnosis, aniridia with congenital glaucoma, intense epiphora, photophobia. Of course, he needed a combined trab with trab, and this turns out to be something which we had noticed. Neonatal onset CU with severe iris hypoplasia. Sometimes iris hypoplasia can be so bad that you call it aniridia. Again, a large cornea and no nystagmus, no foveal hypoplasia. That's not aniridia diagnosis. It's a phenotype, yes, but I think we should be relooking these, and I think we as a group would be party to relooking phenotypes rather than just saying absence of iris is that. So this is a CYP1B1 cytopathy, and it's important to recognize these. So to summarize, I think clinical examination is the hallmark of management of all childhood glaucomas, just as all glaucomas. And ensuring good vision is our goal, not IOP therapy, but we need to look out for the family because many of these glaucomas might be inherited, and we need to hold these children's hands lifelong. Thank you. I, of course, invite you to the IPGS, and I thank all my senior residents over the years who really have a tough time, but they come out, I think, richer by the experience. Thank you.
Thank you, Sushmita. So we are open for questions. Any questions? Yeah, there's a mic at the back, Sushma.
So, yeah, I just wanted to ask about the aniridia part. Now, when we have aniridia with say CYP1B1 where we don't have a classical aniridia, so would our management change in terms of visual rehabilitation, in terms of glaucoma management?
Prognostically, it would change. That's one.
Yes.
You wouldn't be bothered so much about the family. Systemically, it would change. You wouldn't be looking for Wilms tumor. You wouldn't be looking for genetics will help. And the prognosis in the sense of you can have 50% of aniridias without glaucoma. So just having an aniridia does not essentially mean that it is glaucoma. But if it's biallelic CYP1B1, I would tell them that the fovea is fine, everything is fine. If you have a good pediatric cornea specialist with you and you're lucky, then if the keratoplasties are done, they would do better. So in that sense, these are two different diseases. A biallelic CYP1B1 is a very different disease from PAX6 aniridia. And,
Yeah,
you know
and
that.
I think also in terms of inheritance, so
Yeah.
would that
Yeah, so
is
that's
another thing
homozygous
that
recessive.
adds.
You would have parents who are carriers, whereas a PAX6 would be autosomal dominant. So one parent would be a carrier, but the chance of the rest of the families would be 50% for each child, where aniridia is concerned. The same thing for Mendelian genetics, yes.
As any autosomal dominant.
Yeah.
Yeah, thank you.
It's a difficult situation compared to primary congenital glaucoma aniridia. Even if you are controlling pressure with a surgical approach, long-term follow-up may reveal intraocular pressure is still rising, second surgery is required. Sometimes corneal edema is not clearing totally and scar is there. You may have to go for penetrating keratoplasty. And that again brings back the high pressure. Pressure again rises. So sometimes multiple surgery. We have several children where multiple surgeries were done. Children are doing reasonably well, but overall prognosis is poorer compared to primary congenital glaucoma.
And just to add, Sushma, the added problems of a limbal stem cell deficiency aren't there. So there will be no keratopathy. I would be far more inclined to get a keratoplasty done for CYP1B1 rather than an aniridia because they really do well. So the keratopathy part is lesser. So as I said, they're two completely different diseases. But if we treat them all as the same, it's possibly not.
I have one question.
We have done combined trabeculotomy, but having said that, in some cases, embryological abnormality may reveal that Slem's canal is, you cannot find it out. In that case, you may have to convert it to trabeculectomy. And the iris stump should be removed carefully, otherwise it will block the ostium again.